The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here to do another issue of the Genuine Article, and we're going to discuss a manuscript that's in press in JACC that's very, very interesting. It's from Dr. Majboom and Associates, and it's a multi-center study that looked at the diagnostic accuracy of 64-slice CT angiography in the identification of coronary artery disease in patients who were already scheduled for cardiac catheterization. And to help discuss this case is Dr. Steve Nissen. Couldn't think of anyone better. And Steve wrote a very, very nice editorial on the study, and one that really sets CT angiography in proper perspective. So, Steve, you might review the specifics of the study quickly before we get into our discussion about CT angiography.
Well, this study, like almost all others in the field, shows a high negative predictive value for the test, but a relatively low positive predictive value. So CT angiography appears to be effective at ruling out disease, but when you see disease, the disease may or may not be there. This raises a lot of concerns about application. You know, we have a tendency in our field to rush to judgment. Every new technology has to be used by everybody. We've got these CT scanners going in some doctor's offices, and of course, to a man with a hammer, everything looks like a nail, so they're getting used.
So, as I recall in this particular study, the patient population was appropriate, and in fact, there was a good level of disease. Many of these studies have dealt with only very low-risk patients, and so the negative predictive value turns out to be absolutely spectacular, because it would have been good even if you didn't do the study. But as you point out, although they were able to identify disease frequently in patients, when we went to vessel specificity, it was a little less accurate.
It was. And we need to understand that the angiograms that are made with CT angiography are not very good. The quality is poor. There's a lot of artifact which can look like a lesion. And so some of those lesions that are seen really aren't there. But there's a deeper problem. And the deeper problem is that I have believed for many years that the stenosis is not the issue. It's the impact of the stenosis. And so all of our history that we've learned in developing nuclear scintigraphy and exercise echo was designed to find out whether an obstruction was significant, was producing a functional impairment. CT angiography doesn't give you that. All it does is tell you that there is something in the coronary. And so for an expensive test, one that involves a lot of radiation, enough radiation to induce cancer in some fraction of people who actually undergo it, and doesn't tell you whether there's ischemia there or not, I don't see where the value is at its current level of development.
Well, the line pair resolution certainly isn't the same as conventional coronary angiography, as you point out, and that does lead to some problems. I think there's a consensus that for screening this may not be a great technique, and you coined the term luminogram, and that's really what we get. Do you think that if the technology is enhanced, and in fact if it can show us the vessel wall, that this could ultimately be a very useful technique?
I think if you look into the distant future, that's possible. But you have to think about what resolution you need. The lesions that we're looking at in the vessel wall are measured in microns, not in centimeters. And, you know, something which has a resolution of, you know, 0.5 centimeter or something like that, it's just, these are really crude 0.5 millimeter, excuse me. These are very, very crude techniques. And so I think that we're a long way from having the precision that we need to actually look at plaques in the wall of the artery. And it's a really big stretch. Not to mention the fact that the temporal resolution of the technique is relatively poor. And so you have to gate You have to try to stop motion. We learned decades ago with digital angiography that it's very hard to stop motion and to gate these images. So there are many, many problems to be overcome. My concern is that if we suddenly start using this everywhere without ever validating its performance in relation to nuclear scintigraphy and exercise echo, we could be taking a step backward.
Well, I think your point's very well taken. Hopefully in the future, CT angiography will increase in resolution, temporal and spatial, and perhaps show us the vessel wall. For now, I think this very well done manuscript in JACC points out that there are still limitations to the generalized approach using CT angiography, and we ought to await further developments. For the Genuine Article, I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.